Today I'll be talking about a Mohs procedure for limb salvage, a case of squamous cell carcinoma. My objectives. When to consider a biopsy of a foot lesion. We kind of touched upon that earlier. How do we biopsy and properly bill? You made a diagnosis, now what? And I'm going to finish off with a case presentation. When to consider biopsy on a foot lesion. On the foot, skin cancers don't always look like skin cancers. We often get referrals from primary care physicians or other doctors for warts, calluses, diabetic foot ulcers, even athlete's foot. The problem is when a lesion lingers more than 4 weeks and you're doing conventional treatment, it may be something more serious. I teach the residents something simple and a rule of thumb. You may have ulcers, you want to offload them. If you know the reason or biomechanically reason why this is happening, then okay, that's one thing. But if you're dealing with something that's not responding to conventional treatment, it may be something more. Give it 4 weeks. If it's been 4 weeks and it hasn't changed but rather worsened, biopsy it. There are certain red flags on when we should biopsy on even initial visit. Unexplained non-healing ulcer or lesion that lingers more than a month. The patient is describing to you changes in size, color, or texture, lesions that bleed, cross, or cause pain without trauma, pigmented lesions with irregular borders, and importantly, if a lesion keeps coming back, this should raise suspicion. It becomes even more critical in high-risk patients such as diabetics or immunocompromised patients because simple examples of squamous cell carcinoma can progress faster, and this could mean the difference between limb salvage and amputation. High suspicion, immediate action. It's better to explain to the insurance why you acted swiftly than to explain to the patient why you didn't. Deferring high-risk lesions may expose the provider to liability if the patient fails to follow up or later diagnosed with advanced skin cancer. Here in New York, the jury in 2006 awarded a plaintiff $1.2 million because nothing was done until later on. It was a 62-year-old patient with diabetes and rheumatoid arthritis on methotrexate. He presented to the doctor's office with a painful plantar lesion. It had areas of slight pigmentation and bleeding. The doctor said, let's try offloading it. I'm worried about biopsying it because it may leave you a larger wound that you may not be able to heal from. The patient didn't follow up until 6 months later, and at that point, it was diagnosed as advanced acrolentiginous melanoma. The court found the physician negligent for not performing an earlier biopsy on a suspicious pigmented lesion and missed the diagnosis of melanoma, even though they subsequently biopsied it. Dr. Trepel went over different ways to go about biopsying. Just keep in mind a shave biopsy is for raised or superficial lesions. They don't really provide us a good Breslow stage on the foot when you're dealing with melanoma. Punch biopsies are a form of incisional biopsies. It's a punch tool that goes through the tissue. This is most commonly done in the podiatry realm, and I'll go a little deeper into that. Incisional biopsy, a small wedge is removed from a wound. It's good for larger lesions, and make sure you give the histopathologist proper orientation as well as a picture. Excisional biopsies are typically not done in the office because you really don't know what you're cutting into. And for example, when dealing with melanoma with a depth of 2 millimeters, you have to do a 2 centimeter circumferential wedge as well as a lymph node biopsy done by a general surgeon, and that's not something you have in your office. And curettage, a dermal curette, is used to scrape a wound or a wart. This is not really a biopsy technique, and it has high false negatives. So what is a punch biopsy? It's in this schematic, you can see a punch tool is going through the epidermis, dermis, and subcutaneous tissue, and it's a full thickness core, and it's considered a form of incisional biopsy. It's good for diagnosis non-healing ulcers. It gives us depth when you suspect squamous cell carcinoma or melanoma, and it's most commonly done in the podiatry realm. Just keep in mind you want to do multiple punches. How's the step-by-step of going about doing a punch biopsy? When dealing with large lesions that are 1 to 2 centimeters, you want to do multiple punches. You want to find the most viable part of the edge of the ulcer that's indurated or pigmented. Give anesthesia. It's dealer's choice. You could use 1% lidocaine plain or dilute it with epinephrine. Put the punch tool perpendicular to skin, just punch it through. Rotate it downward until the whole tool enters the into the area you're trying to biopsy. Lift the core out. Sometimes it's stuck in the biopsy tool and you want to grab it with forceps. Sometimes it's still attached to the wound. You just want to grab it with forceps and cut the base off with a scissor or a blade. Apply a little bit of pressure. You may want to put a chemical agent in there. And if it's greater than 3 millimeters, consider putting a suture. Dress it. Tell the patient to keep it keep the dressings clean and dry intact, maybe until they follow up, or a few days until it scabs. So large lesions, multiple punch biopsies. So think of a large lesion like a chocolate chip cookie. When you take a bite of an edge, you might only get dough but no chocolate chips. Taking multiple punch biopsies increases your chances of catching those chocolate chips, those malignant cells we're looking for. So here is a patient that came to Metropolitan Hospital. To the left is his foot. He was told this is a diabetic foot ulcer, and we're going to offload it. This is the patient's own picture. This is how he presented in the Metropolitan Hospital 6 months later. He said, my diabetic foot ulcer is not healing. I ordered labs and took 3 punches. His A1C was 4.1. And I did a chart review from his doctor. He never had diabetes, and the doctor never even ordered a lab work on him. So this was not a diabetic foot ulcer, but in fact, unfortunately for him, it was melanoma that's already advanced with node involvement. I took 3 punches, and as you could see in punch C, just like Dr. Truppel gave an example, punch C, it was in the third interspace, showed no evidence of melanoma. If I only took 1 punch in punch C, I would have misdiagnosed this patient as well. Bill and tip sheet, what do you have in your note? Identifications of a biopsy, your concern, lesion description, location, size, appearance, duration. Type up a procedure note, type of biopsy, punch, number of biopsies, location, what type of anesthesia, hemostasis, what you did with the specimen, the patient tolerance. Typical diagnosis codes is L85.9, unspecified lesion, or D48, neoplasm on certain behavior. CPT code is 104 for your first biopsy and 1105 for each additional biopsy, and you want to use a modifier 25 if the patient was there for something else, maybe to get their toenails clipped and you saw something else. All right, most of the time lectures stop there, but now you got the biopsy results, now what? Biopsy and skin cancer is only step 1. Timely referral and coordinated care is crucial for survival as well as reducing litigation risk. You want to review your pathology report prior to seeing your patient, have understanding of what you're going to talk to the patient about, and give a printout to your patient. You want to notify the patient. Sometimes you might have biopsied something that looked like nothing to you and looked like nothing to the patient, and now here you are, the one telling the patient they have cancer. So you want to document that conversation and make sure the patient understands the urgency of these referrals, as this little skin lesion has the potential of killing them. You want to refer immediately, and as a podiatrist, you play a supportive role. You may start offloading that area, start doing glycemic control, risk factor modifications, and coordinate care for the patient. What are our referral pathways after skin cancer diagnosis based on a National Comprehensive Skin Cancer Network? Melanoma, you want to refer to a dermatologist, oncologist, or surgical oncologist. Squamous cell carcinoma, you want to refer to a dermatologist, specifically a Mohs surgeon, plastic surgeon, or general surgeon. Basal cell carcinoma, once again, to that dermatologist. Atypical nevus or dysplastic nevus, it may come back as nothing. You still want to make a referral to that dermatologist because they may need monitoring, re-excision, and quite frankly, a full body scan once over. Sarcomas or rare tumors, an oncologic surgeon, because it requires multi-specialty board. So here's a case, 65-year-old male with complex medical history of HIV, HPV, hypertension, sickle cell disease, presented in my private office. He's a daily alcohol and tobacco user. He had this non-healing plantar lesion for 1 year. It started off as interdigital maceration in his 4th web space. He went to his primary care doctor. He told him this is fungus, gave him a cream. He tried the cream for 6 weeks. It didn't improve. So the primary care doctor sent him to a dermatologist. The dermatologist told him, yeah, sometimes creams don't work for fungus in this area. I'm going to give you a pill. Try this pill out for 3 weeks, and then come back and see me. During that 3-week time, it no longer became macerated, it became crusted and painful. So where did he go? To an urgent care doctor. The urgent care doctor says, oh, the first 2 doctors told you it's fungus, it's healing, it's getting better, it just needs to come off. So start doing vinegar, water soaks. So this patient started doing vinegar and bleach water soaks. He tried that for 3 months, it wasn't helping. He has all these other ailments going on, and basically paid it no mind until it became extremely itchy, painful, and now it began to bleed. And he was dealing with own health issues. One thing led to another. One of his friends is a mutual patient of mine, so he came to my office self-referred. So how did it look like? Vascular, he had intact pulses. Neurologically, he had a normal protective sensation. And what do we see here? We see a crusted, pigmented lesion from his 4th interspace, and it goes plantarly to the 3rd digit. So I'm thinking to myself, okay, this could be crusted tinea with deep invasion. It could be verruca vulgaris, melanoma. He has HIV. It could be Kaposi's. It could be squamous cell. It could be multiple things. I really don't know. But what did I do? I biopsied it. I took 3 punches. All 3 punches came back as squamous cell carcinoma in situ, extended into the periphery margin. There was no atypical myelinic proliferation, even though it was pigmented. PAS stain was negative for fungal elements. So I made the referral to a general surgeon. This is the exact snippet of the general surgeon's plan. Medical history: HIV, recurrent HCV, sickle cell disease, hypertension, presents for follow-up for chronic wound, 5th digit, alongside other lesions on the bottom of his feet. Likely requires a transmetatarsal amputation of right foot per podiatry, PET scan for outside facility, hematology for pre-op clearance, sickle cell disease, anemia, and follow-up with urology with penile lesions. He had all the lesions in his body. Because he had all the lesions in his body, he was referred to a dermatologist. The dermatologist of the hospital calls me up. And he says, "Hey, how you doing, Dr. Jabra? I'm also looking at this guy's foot. I know the general surgeon wants you to do an amputation, but we have an outside Mohs surgeon that would like to take on this case. Could he see your patient?" Sure, he could see my patient. So this is their exact snippet. Dr. Jabra referred the patient to a Mohs surgeon for management of his right foot squamous cell, genital and oral verruca, and we'll plan Gardasil vaccine, a patient that met chirosurgery debulking lesions at that facility. He followed up with the general surgeon. The general surgeon says he was unable to get the PET scan, and he recommended me to proceed with the TMA. He said that outside person that's doing Mohs is doing it pro bono. God knows when he's going to do it. By the time he does it, it's no longer in situ, and just proceed with transmetatarsal amputation. So what do? I'm just a supportive role, like I said earlier. So it's the patient's decision. So I discussed with the patient because he says, "I don't really know what the heck is going on." I said, "The first guy says you should have an amputation so we can excise this cancer. It's bleeding. It's been there for a year. It could be something more than what we think it is. The dermatologist wants to remove this. It's going to leave you a large wound, but we'll deal with it." So what does the patient say? "Let's proceed with Mohs surgery for limb salvage." He accepts that there's going to be wound care needs. He understands amputation remains as a backup. So how did it look after Mohs surgery? Mohs surgery, they cut out the wound, and they make sure they got a clean margin. It's not that simple. There's multiple frozen sections. For this squamous cell, the surgeon took 6 hours to do this procedure, and one of our residents was in his office helping him, which was nice. As you can see here, this is how it looked like after the procedure. There's a large wound defect. So what am I thinking now? Because now I'm playing the wound care. Wound healing, it could heal by secondary tension or skin grafting. I called the dermatologist. I said, "What do you think about me taking a skin graft?" He said, "The patient has multiple more comorbidities. There's seromas and whatnot. It may not adhere. Let's just do secondary intention." So week 1, there was a malorder. I used diluted bleach water. Told him to do dressing changes every 2 days. This is it. Week 4, it's granular with islands of epidermis. This is it, week 5. I have more than 50% healing, so I'm sticking to the plan. Now, week 6, the whole plantar aspect healed, but I failed to mention, it looks like he doesn't have a 5th toe. He had extreme pain upon the first dressing change, so he couldn't tolerate dressings between his toes. So I discussed with him, if we don't put anything between them, you can have a syndactyly. He goes, "Listen, at least I have my foot." So this is week 6. The toes have syndactylized, the wound is almost completely healed, and this is him 3 months later, cancer-free, with a healed wound, and he follows up regularly with a dermatologist for skin monitoring. And that's it. Thank you.